Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
Hello everyone, and thank you for joining us today for this webinar on the comprehensive and personalized approach to managing patients with metastatic hormone-sensitive prostate cancer, trying to fit the right pieces for each patient. So I am joined by my colleague and friend, Elena Castro, and I'll just introduce myself and then I'll let Elena introduce herself. So I'm professor and chairman of the Department of Surgery and head of GU Oncology at the University of Montreal, and I'm very happy to be part of this group. Elena?
Hi, Fred. It's very nice to have the opportunity to talk to you again. And I'm a medical oncologist from Madrid in Spain. I treat mostly patients with prostate cancer with advanced disease. And I think this topic is very relevant because it's fantastic to have many treatment options, but sometimes we find ourselves trying to identify which could be the best option for the patient in front of us. And this is what we are going to discuss today.
Absolutely. I mean, it's great that we have all these options. Unfortunately, they're not always used, and I think there's still some work to do, but hopefully with this webinar, we'll try to dispel some of the myths. So let's start straight with a clinical case. I think it puts things into perspective of this 73-year-old healthy patient who presents with urinary symptoms, had a positive history with his father and brother, and so he never got checked for prostate cancer. With all the controversy around screening, he was never really tested, but because of his symptoms, he went to consult and he had at least a rectal exam that found an abnormal digital rectal exam suspicious of cancer, and his PSA was elevated at 95. Biopsy confirmed Gleason 4+5 prostate cancer, and he'd had workup for metastatic disease, and unfortunately, he had enlarged nodes in the pelvis and retroperitoneum, no visceral mets, and bone scan revealed 3 suspicious lesions in the spine. So let's jump to the first question. Which systemic therapy would you offer this patient, 73 years old, healthy, with low volume, hormone-sensitive metastatic disease? Would you give him ADT alone? Doublet therapy of ADT plus an ARPI being androgen receptor pathway inhibitor like enzalutamide, apalutamide, abiraterone, etc. Or triplet therapy with ADT and an ARPI plus docetaxel, and in this case, the choices of ARPI would be darolutamide or abiraterone.
Yeah, this case is interesting because if we try to classify it, it will be high risk as per latitude criteria, but low volume as per Chartier criteria. So in the limit.
Yeah, absolutely. So I guess this is pretty good news. That only 11% would offer ADT alone. We'd like to see 0% because whether, like you say, whether it's high volume, high risk, low volume, low risk, this patient, I think, can benefit from more than ADT. What do you think of these results? Do you think it's a good split between doublet and triplet therapy and those that would do more than ADT?
Yes, I think is very good to see these results. To be honest, this is why I was remarking that the patient could be classified as high risk but the low volume, because in this situation, perhaps is one of those cases that is not very clear for sure. I will offer this patient an RP, and perhaps I will discuss whether to add docetaxel here or keep it for later. And is one of those situations in which the decision will be a bit tricky and definitely something to discuss with the patient. I would like to learn and we cannot hear from them, but from the audience, but it will be interesting to learn why some of the attendees consider ADT alone for this patient. Is it because of the age? Is it because they are not very convinced with the evidence we currently have? Is it because any other reason? Because I think we have compelling evidence that ADT alone should be only kept for a minority of patients.
Yeah, exactly. And there are some realities around the world that could be access issues, cost issues, but I totally agree. But I think it is quite reassuring that at least 90% will give at least more than ADT. So, I think this is one of the reasons we really need to do more than ADT, and it comes from the STAMPEDE ADT alone arm. And as everyone knows, STAMPEDE is a large multi-arm study, but the control arm for metastatic disease was for a long time ADT alone. So it gave an opportunity to see in a relatively contemporary cohort what happens when we do ADT alone and leave treatment for when patients become mCRPC, where we had life-prolonging therapeutic options. So what we see here is that in about a year, 11.2 months, patients became castration-resistant because there was failure-free survival, including PSA elevations. But what's most sobering is that survival was only about 3.5 years in these patients, even though we had good effective therapies when they did become CRPC. So what the take-home message is, patients will develop castration resistance quite quickly. And if you wait for castration resistance to introduce therapies that are effective, unfortunately, the advantages are much lower than what we see today by giving something more than ADT alone for these patients. And what is reassuring is that multiple studies now with ADT alone arms are showing around 1 year time to CRPC. So I think this is a little bit overwhelming, but this is a good thing. Like you were saying, Elena, now we have a lot of choices for patients who are hormone-sensitive, metastatic, whether it be doublet therapy with chemotherapy, doublet therapy with an ARPI, or more recently, triplet therapy with the combination of an ARPI plus docetaxel. Basically all of these studies showed clear improvement in outcome over ADT alone in all of these multiple studies. And if we take it piece by piece, docetaxel alone, apalutamide alone, abiraterone alone, enzalutamide alone, added to ADT, did much better than ADT alone in all of these studies that either used docetaxel or an ARPI doublet therapy. And now, more recently, we have data suggesting that if you hit the cancer with two different mechanisms of action, docetaxel for chemotherapy plus an ARPI, and here we had abiraterone in the PEACE 1 study, which wasn't designed initially to address the question of triplet versus doublet. And then we have ARASENS that really did look at, from the very beginning, the value of combining docetaxel with darolutamide compared to ADT plus docetaxel alone, showing clearly an advantage in overall survival in patients getting a triplet approach versus a doublet approach. And in this case, the best available doublet when this study started was ADT plus docetaxel, which is still considered a very effective doublet regimen in patients with metastatic disease. I don't know what you think of these results. This is what we use to make decisions, but like you're saying, the patient has to be part of that decision, Elena.
Yes, no, I was thinking that perhaps some of the attendees that voted for ADT alone practice in regions or in places where they don't have access to RPs, and then we didn't include the option of adding docetaxel to ADT. And the reason for that is because after the Arasens and the PS1 trial, we have already decided that those patients that are fit for docetaxel or eligible for docetaxel should get a triplet instead of just docetaxel. But it's true that if someone is practicing in a place in which without access to an RP, I think the data you show tell us that treatment with docetaxel is superior to ADT alone. So perhaps we should have included that option. We forgot that one.
Yeah, no, that's that. I think that's a very fair point, and the Lancet Commission on prostate cancer really tried to address inequalities around the world in terms of access, economics. So clearly, I mean, if we can't access an ARPI, a doublet form, including docetaxel, should be at least offered for these patients, at least for the high risk, high volume patients, where the benefit seems to be the strongest. Totally agree. So I'll just share some data that has just recently been presented and published, looking at an additional ADT ARPI combination, and this is using darolutamide without chemotherapy, because we had the data when we add darolutamide to docetaxel, we do better than docetaxel alone in combination with ADT. So here it was to address this issue of, can we use darolutamide without docetaxel? Because many patients and physicians like to have multiple options to exactly, as you said, Elena, tailor our treatments to maybe the patients in front of us and give them multiple options. So this was a study that was done, randomized international study looking at darolutamide plus ADT versus placebo plus ADT. Given the fact that we already had 2 phase 3 studies showing that darolutamide could prolong survival in the non-metastatic CRPC and the hormone-sensitive setting, we didn't feel we needed to do another overall survival study that would have taken much longer and much greater numbers. So the rPFS was the primary endpoint with multiple secondary endpoints. And I'll just very rapidly, that study met its primary endpoint, significant improvement in rPFS in these patients getting darolutamide plus ADT compared to placebo and ADT, 46% reduction in the risk of progression or death. And to support that data, again, time to mCRPC you see occurs in about a year, 13.8 months in the ADT alone arm, and it wasn't even reached in the combination arm with darolutamide. So 60% reduction in time to mCRPC. Time to pain progression was also delayed by 28%, which is, I think, what patients want, is to delay symptoms as long as possible. And PSA response was more than 3 times more in patients getting darolutamide than those that got ADT alone, going from 18% to 62%, and almost a 70% delay in PSA progression, which very much correlates with time to mCRPC. And one of the reasons we did this study was really to get a sense of darolutamide without chemotherapy, the tolerability compared to a placebo. And we saw very little differences in adverse events. And a little bit to our surprise, there was actually less fatigue in the patients getting darolutamide over the patients getting placebo. Obviously, there's no reason to have less fatigue, but maybe with better cancer control, patients didn't complain of fatigue as much. So I think this is very reassuring that we don't seem to worsen the adverse event profile of ADT alone, which might be, again, one of the reasons why some people continue to give ADT, worried that maybe the added side effects bother patients and cause physicians headache. So, this is your area of expertise, Elena. Your international reputation is on, looking for mutations and acting on them. So I'll ask the audience, would you screen for a BRCA mutation or a HRR mutation?
Alteration, yeah.
Alteration at the time that these patients are diagnosed?
Oh,
This is a very educated group. So,
it seems that, well, or it was your introduction also to the question. Well, the thing is, currently, we don't have evidence to use a PARP inhibitor for patients with mHSPC. So the data, we have 3 clinical trials that with different agents that have been conducted, and we may learn soon whether there is a benefit from using a PARP inhibitor in this scenario. But as of today, we shouldn't use these PARP inhibitors for patients with mHSPC. However, it is also true that the age of the sample has a real impact in the chances of getting good results. So if since the BRCA status or the HRR status doesn't change over time, we can do the test at the time of diagnosis. So at the time of de novo mHSPC or recurrent metastatic disease, we could do the analysis and then keep the information for when the patient becomes castration resistant. That is when we will be able to use a PARP inhibitor nowadays.
yeah.
The other thing is, and this is one of my hopes, is that when we have this data for mHSPC and we really need the results of the BRCA testing, if the pathologists will be able to do it when they are assessing the specimen for the first time, I think it would be much easier because that will save us a lot of time, a lot of issues retrieving the bloods, going back to the, so that would be much easier. So I hope we see that in the near future. But apart from treatment, it will be important to know if a patient has a germline, BRCA or HRR alterations, but because that will allow us to counsel not only the patient for prognosis or the possibility of a second tumor, but also to test and counsel the relatives. And I don't know what is your experience, Fred, but sometimes I have patients in my clinic where we test the man with the prostate cancer, and it turns out that he has a daughter with breast cancer who was not tested because she didn't fill the criteria for BRCA testing in breast cancer because she was older than 45 or she didn't have a triple negative or whatever. So sometimes, even with a family history, no one else has been tested.
Yeah.
So it's important that we offer testing to our patients.
Yeah, totally agree. And that's what we're doing now is our pathologists are doing it at the time of diagnosis of a very high risk, or especially if we know already that they're metastatic, doing it immediately. The value of that test is much more informative when the tissue is fresh. Totally agree. And we saw that with Profound. And if you limit to germline, I think you've reported on this that we might miss half of the patients with mutations if we limit testing to only germline. So doing it on the tissue is much higher likelihood of capturing these patients that need to be acted on. So now, if the same patient had greater than 10 bone metastases, would this change your treatment? We saw that it was pretty much split between doublet and triplet. So let's ask the question, if you had more than 10 bone metastases, would you still have the same approach? Okay, well, now we're up to 75% and only 2% would give ADT alone. So I think either people look for these higher risk patients before adding, but I think this is very reassuring. What would you do yourself, Elena? We obviously don't have much time left in this discussion, but...
Yeah, I will agree with the audience. For a high risk, high volume patient, if the patient is eligible for chemotherapy, is fit and agrees on having this upfront, my preference will be for triplet therapy as well.
Great. So if we go to the next question. So if the patient had liver metastases, would that change your treatment option? We already had 75% with more than 10 bone metastases. So if we can vote on whether the same patient, 73 years old with liver metastases, how would you approach this patient?
I personally will also offer triplet to the patient, also thinking that his liver function may deteriorate over time, and he may never get to receive docetaxel as a second line of treatment. So yes, if the blood test allows and the patient is fit, I will offer triplet therapy in
Yeah,
this patient as well.
these are some of the worst patients with liver metastases, and they very often have undifferentiated cancer. So I would definitely encourage the patient to accept triplet therapy. So we have a question in the audience in terms of treating the prostate in this low volume setting. And clearly that's one of the questions we wanted to address, but would you treat the prostate, Elena, if this patient with low volume disease, 3 bone mets, the initial scenario, would you treat the prostate?
In the initial scenario, yes, because we have data from the Stampede trial that in patients with low volume, treatment of the primary will improve overall survival, contribute to prolong overall survival. Then we have data from the PIS1 that suggests that there may not be benefit in overall survival, but will help to local control. And well, I think these are patients that on one hand are going to be on ARPIs for a long period of time. And there is always this concern of the tumor differentiating into the neuroendocrine variants. And it seems that radiation could also help with that. We didn't have the information about the tumor size, because if it was a T4, for sure, I will offer radiotherapy to this patient.
Yeah, so it's become a routine in our center to treat the prostate with hypofractionation to avoid 35 sessions and simplify the patient's life. And regarding the bone mets, that's a clinical trial question. So treating the bone metastases is something we put in clinical trials, and we do not do routinely to treat bone metastases in patients even with low volume, what looks like low volume. And if we ever thought of doing it, we would do a PSMA to make sure it wasn't just the tip of the iceberg. But outside of clinical trials, we are refraining from treating distant metastases. But the prostate, I think there's good evidence, like you said, that could be helpful.
And several trials are currently ongoing. So for many of us, it will be easy to actually enroll those patients in trials so we can have a definitive answer rather than just treating, because it's in many places it's also a common practice to radiate the bone mets as well. But we need to enroll patients in trials so we can know if there is a benefit or not.
Exactly. So if this patient was 45 years old with low volume, so the same patient instead of 73 was 45 with only 3 bone mets, so low volume disease, no visceral mets, you would do ADT, doublet, or triplet therapy. So does it make a difference for you, the age of the patient, Elena?
Yes. For a young patient, I will definitely offer a triplet, because we know in these patients, tumors are usually more aggressive, and patients are usually in better health status, so they are they could tolerate it better than elderly patients. So yes, I will consider a triplet therapy for a 45 years old with metastatic disease.
Yeah, absolutely. The same with us. At this age, we would encourage, and I'm treating several with the triplet plus the radiation therapy to the prostate. So here there was a split, but I think in these very young patients with, in theory, more than 30 years life expectancy, we want to do the very best we can to keep them in good condition. Okay, so let's just end maybe before we go to some question and answer. There's supportive care. I mean, these patients are going to live hopefully a long time with hormone sensitive. So which supportive care measures would you prioritize for this patient? Bone health, psychological support, lifestyle habits to review them, sexual health support, or would it be all of the above? Which one would you prioritize, or would you try to address all of these issues?
Yeah, so I agree. I agree with the audience. And actually, we should be able to offer to our patients all these supportive measures. But the truth is that sometimes it's not easy because we cannot refer patients to a psychologist, or we don't have an expert in sexual health available. So we have to improve the supportive care that we can offer to our patients. But this is definitely something to take into consideration. But I think we have more and more evidence also regarding the importance of protecting the bones. And this is something that we can easily do in our clinics, and also to review the lifestyle or habits as simple as recommending patients to do some exercise, daily walks, and take care of their diet. So there are some things are more complex, but others are very simple and don't take much time.
Yeah, absolutely. And those are where we put a lot of the priorities, but all of them are important. So in terms of some of the questions before we end in the next couple of minutes that were brought up, one thing that does come up, I mean, if this patient has a really good response for a couple of years, would you stop therapy or would you continue therapy in patients who do well? Complete response.
This is very tempting to stop, isn't it? But it's the same again. We need data, and the studies are being conducted. So I don't offer patients to stop unless they are not tolerating treatment well, or something happens, or there is any situation, or if they ask for a treatment holiday or something like that. But I'm not actively offering them to stop treatment until we have that data. I believe that there will be some patients in which we can stop treatment, but I would like to see the evidence first.
Yeah, and the evidence that we have of these 5-year survivals and everything are with patients that continued therapy. So I agree, until we have more data, it's necessary to keep patients on and to encourage them to continue. And maybe just one last question for your expertise. What other, besides BRCA, which other mutations would you recommend a PARP inhibitor? Are there others besides BRCA that you would be recommending a PARP inhibitor in the CRPC case? Mm-hmm.
In the mCRPC, definitely PALB2 is a gene that is not very frequently altered in prostate cancer, but they are very sensitive. So patients with these alterations usually respond well to PARP inhibitors. So those patients for sure. We have now some data that suggests that patients with CDK12 alterations, when given a PARP inhibitor in combination with an RP, they may respond as well, but not to the PARP inhibitor in monotherapy. This is very intriguing and very interesting, and it would be nice to learn more about it. But considering the bad prognosis of these patients, definitely something to take into consideration. For other patients, as for those with ATM and CHEK2, I will prioritize other treatment first, and if I run out of other options, then consider a PARP inhibitor.
Great. So on those wise words, half an hour is already up. So we thank you very much, Elena, and thank you to the audience for having participated, and hope to be able to speak again in the near future. Thank you very much.